था आपके एंड से. Yes, it is live stream. So I'll introduce, ma'am.
Okay.
So, respected doctors and dignitaries, very good evening to all our honorable guests who are a part of this meaningful interaction today. So, thank you to each and everyone for squeezing time from your busy schedule. Myself, Shavanti Mukherjee, Group Product Manager of Corona Remedies, makers of Stimucor, Nostra, and Dydro Hope. We welcome all of you to today's webinar on Core Connect Live Virtual CME Series 3 on optimizing IUI results. And we also thank our honorable speaker, Dr. Sunita Tandulwadkar, ma'am, President POGS and Senior VP NISAR and former VP of FOXY, for giving us this opportunity to organize today's scientific virtual CME. And it is our immense pleasure to have you today with us on Core Connect platform, ma'am. So now I invite Dr. Sunita ma'am to share her expert clinical insights on the topic of optimizing IUI results. Over to you, ma'am.
Okay. So thank you, Beta. Thank you for your kind introduction. And I think we already wasted 5-7 minutes, so I will not waste much time. Every month on second Monday, we all will be live. Our previous, you can always ask the Corona people, or if you are receiving our flyers, you will know that our previous two are also recorded sections are there in which we have taken a PCOS and overview. And last time we have covered ovulation induction in non-IRT cycle. Today, we will be talking about optimizing IUI. And second Monday of next month, we will be talking on luteal phase. We have all the programs chalked out and you can get from there. So friends, let's talk now 1 hour. I love it here because I can get a time and I can share a lot of practical tips than just the theories. Why we talk about IUI? After failure of expectant management, the next line of treatment, especially young patients, shorter duration of infertility, no severe male factor or a tubal factor, we go into the IUI as treatment protocol.
అది delete చేసేయండి సార్, అది పెట్టద్దు. ఇప్పుడు
Corona remedies, please block your, make yourself muted.
Okay.
Mute yourself. There is a lot of voice which is going on.
మీరు ఒకసారి log. Okay.
Who is talking in a, I think, okay, South Indian language I can hear. Can you mute all the audience at present? And during question answers, we'll make them live again. Okay. So levels at which IUI success can be improved. One, I'm going to tell you, and I will be talking about it. First, most important thing is selection and workup of your patient. The way you do the induction protocol, how you monitor, when you give a trigger, what is the time of a IUI, the technique itself, and the luteal phase support, what you should be going. I'm going to discuss on all these points one by one. Now let's go to the selection of a patient. Usually, these are the 4 indications for which we do the IUI. Polycystic ovaries, unexplained infertility, male subfertility, that let me call it as a mild male subfertility, or endometriosis, because if you ask for a natural ovulation induction and time relation, the success may be just 4 to 6%, while if you add on gonadotropin, you may extend it to 8 to 10%. But if you add on IUI, we can double or triple sometimes in a younger patient. And that's why we do. So let's talk today about my experience, what does the evidence says, and how the patients are presented, we will cover. Now, ovulation induction, I have covered extensively in a last webinar, but I will be talking little bit today also for those who have missed out. Of course, that was a 1 hour plus session, so it was a very extensive session, but I'll be covering in 5-10 minutes what is IUI when we do with the ovulation induction, or when we have to do the ovulation natural cycle. We all know that with the ovulation induction, the success rate will be much better than the natural. whether we should go with the oral or injectable, whether we should use HMG or recombinant, and where do we stand in all these? Let's talk about it. Also, whether our treatment depends in an induction in the patient with the anovulatory PCOS patient or ovulatory. Let's talk about PCOS. Now, I have already discussed that letrozole has replaced or is replacing the first line of treatment, which was a clomiphene, because the Cochrane also says, Cochrane, which is very difficult to give 100% thing, which always also says, yes, letrozole do improve the live birth and a pregnancy rate, and high quality evidence that OHSS rates are similar, if not less, and no difference in a pregnancy rate. So in last time, we discussed that in PCOS, letrozole can be considered as a first line of treatment. Now, when to add gonadotrophins, and if at all, which gonadotrophin? So gonadotrophin comes in a PCOS as a second line of treatment. Either if letrozole resistance or a letrozole failure, we add on gonadotrophin, and we can do the laparoscopic evaluation and the drilling. Now, if you are suspecting that there may be a tubal patency not good, or you are suspecting that there is a tenderness, there may be a PID associated or endometriosis associated, and you wish to do laparoscopy, then you can do the drilling. Or otherwise, the results of gonadotrophins or laparoscopic drilling are the same. This become invasive, and you can think of doing only the gonadotrophin. And when we talk about the gonadotrophin induction, which gonadotrophin, recombinant FSH and the urinary, they are equally effective. There is no increase in a pregnancy rate or ovulation rate or a miscarriage rate with recombinant or a highly purified HMG. So both are equally good. From 2001 to now, the publication has said again and again, in PCOS, recombinant as well as HMG is equal. Use of insulin sensitizers, the metformin, where does the evidence says? Yes, it improves the ovulation rate and the clinical pregnancy, but we don't know whether it gets transmitted to the live birth in a PCOS patient. But when we use a gonadotrophins, then, so if I say metformin, with the oral ovulogen, the live birth rate, we don't know. But when you add on metformin with the injectables, the live birth rate also is increased. And that's what the Cochrane says. Friends, I have explained everything in huge detail in a last session of ours. And I am just saying it that all my patients, I put them on a metformin because we know there is an insulin resistance. I don't bother to check serum insulin level or anything. I just add on metformin and I continue that metformin in a first trimester. Especially if patient is obese, you have a strong family history of a diabetes, I may continue till second and third trimester also. And luteal phase clomiphene, let's not go it. Unexplained infertility, what is the evidence-based approach? Just to give a revision, if with the ovulation induction, there are so many methods, so many ways you can think about doing, and there are so many ways they have done the comparison. What is important is expectant management may be comparable to the treatment with CC and time intercourse. Gonadotrophin always going to be more effective than just the oral ovulogen. And one can think about using the gonadotrophin in a ovulatory, because ovulatory, mainly it may be a mild endometriosis, maybe it may be a unexplained infertility, or it may be a mild subfertility. But gonadotrophin, especially in unexplained and a mild endometriosis patient, we always prefer to add on to the oral ovulogen. And in unexplained, in PCOS, I have told you it is same, while whether urinary or recombinant. But in case of an unexplained, the evidence says recombinant may be little more superior to the HMG. So all my patients of unexplained, I give them recombinant. I have explained you in a previous series why I give you recombinant more in my day-to-day IUI practice, because you can titrate as low dose as 37.5. And the pain can be taken by the patient at home, and we don't have to worry about it. She can do the self-injection, while HMGs are available with 75 and 150. And if your unit is keeping only 150, to titrate to 37.5 becomes difficult. Fast trial, where they omitted the IUI cycle, it is under question because growing evidence supports IUI. While in fast cycle, they have said, even the UK, these were the UK guidelines, and they themselves, only 4% of the people have adopted that IUI is not good, only if expectant line of treatment. So this all we have covered in a last, and the growing evidence tells us, including the Roy handbook, that the IUI has its own place. IUI has become more cost effective, and we should be doing it before we go for the IVF. So ovulation induction, I covered only in 5 minutes because we spoke extensively for 1.5 hours in last. Please refer to it. Now, monitoring of the cycle. This is more important. Our second point, selection of a patient and the monitoring of the patient. Now, selection of a patient, what is very important for you to understand is, if you select the patient, younger patient, good reserve, no more than mild male subfertility, first 2 IUIs or 3 cycles are more successful. So if the patient has done 8-9 cycles somewhere, 2 or 3 centers together, there's no point in doing a IUI again. So if you select, my IUI results are very high, but I do IUI only 7 to 10 IUIs in a month. I have told you before also. Why? Because one, most of the time the patient reaching to me have already failed IVF cycle. There's no point in going back to IUI. But at the same time, if I see my IUI results, they are very high because my selection criteria are very stringent. They should not have any IUI done before. They should be young, acceptable AMH. It means if I have to do the IVF, suppose we are on 14 November 2022, if my results of a IVF will be the same on 14 November 2023, it means I have a breathing time of 1 year. My results are not going to decrease because patient is young, her AMH is acceptable, I go for IUI. So naturally, when you select the patients of a very favorable prognosis, you are going to get the results. Now, once your selection criteria is strict, second comes is monitoring. So what we do is on day 2 or day 3 of the cycle, we always check the sonography and we always see that there is no remnant of a previous cycle. There is no follicles about 10 a.m. How we do in an ART cycle. It's not only that the remnant follicle will become a big cyst, but if there is a high LH and high progesterone at the beginning of your stimulation, the result will not be good. So you ensure that ovaries are downregulated. You don't have to do E2. You don't have to do LH. You don't have to do progesterone. If the patient had a good flow, endometrium is thin, and the ovaries don't have a follicle more than 8-9 mm, it means her LH has to be below 2 or preferably below 1. Her E2 will be below 30 and progesterone will be below 0.2, 0.3. So no need to do hormonal monitoring. It is sonographic monitoring on day 2, day 3. Now I start the stimulation. When do I monitor? Usually by day 7, day 8, I do the first sonography. And I have told last time also, if I have to add on gonadotrophin, I always give oral ovulation plus gonadotrophin. Now, when we do from day 8, the monitoring. Now, on day 8, if I find the follicles are of 14, 15 mm, I will call the patient every day. If I see the sizes 11 mm, 12 mm, I'll call the patient after 48 hours. She can take the gonadotropin at home herself, continue the gonadotropin. Remember one thing, if you are starting the gonadotropins, you cannot stop them till the day of a trigger. And that's why, to make the cycle cost effective, start a very low dose of 37.5 or 50 per day, maximum 75 per day. Don't start with the higher, because our aim is not to blast the ovaries. Our aim is to stimulate 2 or 3 follicles. One single versus 2, 3. The studies have proven that when there are 2, 3 follicle, your IUI results will be better. I also feel maybe 1 follicle on one side, 2 follicle on one side, the patient ovulates from both the side, the chances of success will be always high. Now, sometimes the people or many gynecologists don't do the sonography by themselves, and the sonologist will do. I will always say, if you want to optimize, self-sonography is preferred over the referral. But if you are doing it from your sonologist, ensure he doesn't give you only the leading follicle. He also mentions you what are the rest. Usually what happens is, leading follicle may be 14, but there may be 11 and 12 mm, many more follicles, 7, 8, 10. You will land up in OHSS. So very important that your sonologist does 3-dimensional, because if you do with the single diameter, and if he has taken the follicle oblong, like an egg, try to imagine an egg. If I take a vertical, it may be 14. If I take a horizontal, it may be 10 mm. He may be writing 10, he may be writing 14. So very important that you get either 2 or 3 diameters. Second important thing is, they should always comment on endometrial thickness. Why? I have explained it last time also. Endometrial thickness, trilaminar, getting formed, it means a follicle, it is carrying, housing a very good oocyte, so that the estradiol levels are good. Now, if you got 2, 3 follicles and the endometrial lining, so I have a habit of getting an endometrial lining. If endometrial lining is not good, only that is the time you have to do the E2 value. It will tell you 3 follicles, E2 value 20. You are not going to expect the endometrium to come. But E2 value 200. It means the endometrium has to be there, and probably this lady has uterine cavity problem, refractory endometrium. So these are the only condition where I do hormonal monitoring, otherwise only sonographic monitoring. So if there is a disproportion between the endometrium and the follicles, you should be doing the E2 to find out whether the problem is at follicular level or the problem is at endometrial level. So always prefer your own hormone. We will do only when. I don't do LH monitoring and all. I just do only sonographic monitoring. And blood versus urinary, I don't do urinary LH and all. I do only estradiol level. So what is important is, don't bombard the patient with too many monitoring with us and make the cycle expensive. Ultimately, the result is going to be below 20%. Your 1 in 5 patient is going to conceive. So don't make the cycle expensive, and try to be as economical as judgmental. Now, again, in a monitoring, if you have a color Doppler, or those who are doing a color Doppler, I want to tell you one thing. We do Doppler studies for the follicle also. And if 70 to 80% of the follicle is having a good blood supply, it means it's going to be about to be ovulated. At the same time, you should do the Doppler for the endometrial lining. You should have up to grade 2, or maybe it will reach to grade 3 on the day of ovulation. Suppose you have a beautiful lining, but the Doppler studies are not good. You just try to see uterine artery pulsality index, whether the blood flow is going well or not. You might add ecosprin to these patients. You may do PRP. See, try to mimic the cycle. So if I see that the lining is good and everything, the vascularity, you can think about improving the vascularity by adding the EcoSprint to the patient. So very important monitoring. So now, if the follicle is 14 mm, I'm going to do everyday monitoring. Before 14 mm, the follicle grow on an average by 1.5 mm per day. Usually after day 14, 15, the follicles start growing little more rapidly. And that's why try to do after 15 mm, very close daily monitoring. Why you should do alternate day before 14? Because there's no point. If it was 11, why I need to see at 13 mm? Why I need to see at 15? I probably will call after 48 hours. So you decrease your OPD workload of a routine sonography for IUI patients. Now, when do you give a trigger? So monitoring, we understood, mandatory on day 2 and start from day 8 and depending upon the cycle, whether alternate day or whether daily. Now trigger, when do you give a trigger? And if at all, what trigger I should prefer, LH or SCG? So let's talk about first and then the timing of IUI. So I will go first is about the trigger. When do you give a trigger? I give a trigger at around 19 mm follicle. The studies, the books says 18 mm, some books says 20 mm, some says when you are using oral ovulation, give at 20 mm, and when you are adding gonadotrophins, give at 18 mm. Now, why do I give at 19 mm? Because I give margin of 1 mm to my fellows for the error in their sonography. So if my protocol would have been 18 mm, and if they are giving at 17, or my protocol is 20 mm and their measurement goes wrong, the 21 mm, 22 mm, I give a margin. So usually you can consider between 18 to 20 mm. Now, when I'm doing a sonography, I try to make follicle as round as possible to avoid the error in the measurement. But at the same time, if it is a 17 mm, I do my all sonographies in the evening between 4 p.m. to 7 p.m. So if the follicle is 17 mm and yesterday it was 14 mm, it's going very rapidly with the gonadotrophin. So I may back up the SCG trigger to the patient and ask her to take. So when you are doing a monitoring, try to behave that you are the follicle. I'm going with the speed of 2 mm, 2.5 mm, and today it is 17 mm. I may expect that instead of 24 hours, the follicle might be at 19 mm early in the morning at 10 a.m. only. So I may pack up the SCG injection in a cold chain, explain her to keep in a ice tray, not in the freezer. And if they have a double door and there is no ice tray, which is not there in many modern fridge, they can keep in the door compartment next to the freezer. Okay, but not in the freezer. So I may carry. So you have to have your own judgment. More and more cases you will do, you will get to see. Now, if I have to give a trigger, do I give a LH trigger or SCG trigger? Friends, I give always SCG trigger and I give 10,000 dose. And if I'm using recombinant SCG, then 1 ampule of recombinant SCG because it has a 6,500 units. I don't give 2 units. Now, do people give a LH trigger? What is the difference between a LH and a SCG trigger? The LH has a very short half-life, just 24 to 36 hours. So you have to give a good luteal phase support. While SCG, the half-life is 7 days. So it can work as a luteal phase support. And by 7th, 8th day, if the pregnancy has happened, the corpus luteum will continue to grow and will give endogenous estrogens and progesterone. And you may think that this SCG alone may be enough. In a next meeting, we are talking about luteal phase support, and I will talk about it much detail there. But I prefer to give 10,000 SCG. Now, some people will ask when you do the timing and do SCG I have given today at whether I should do at 24 hours or I should do at 36 hours. The publications, evidence says 36 hours. And you should time your IUI at 36 hours. But I don't do that. Now, why? As I told you, I do my monitoring in the evening 4 to 7. Suppose I have seen at 5 a.m., follicle is beautiful, 19.5, I want to give a trigger. I gave a trigger at 5 p.m. When the 36 hours will happen? It is a Monday today, 36 hours will happen Wednesday, 5 a.m. Are you going to get up at 5 a.m. to do the IUI? No. When the patient will arrive, 8:30 when you open your center. By the time he gives a semen sample, by the time the IUI is done and performed, even at the earliest, it will not be before 10:30, 11 a.m. So I'm doing IUI practically at 40 to 43 hours, which is wrong. So try to understand the timing of IUI should be as near to the ovulation as possible. So in my center, 36-hour policy will not work. Second, I am not stopping endogenous LH secretion because my patients are not downregulated. They are not on antagonist or leupride agonist. So if I'm not giving an antagonist, the body LH surge, when it will happen, anytime when the E2 value is crossing 200 picogram. Now, if E2 value is crossing 200, from that point, if LH surge is going to start happening, imagine you have 2 follicle and the E2 value is 500. It means her endogenous LH surge has already started. And when you give a SCG, it has already, suppose her endogenous LH surge has started 12 hours before or 20 hours before. So the trigger which you give is not going to calculate 36 hours from your trigger day. The follicle is going to rupture 24 hours prior because the endogenous LH surge has already started. So what I do in my center, second important thing is in IUI, when you wash the semen sample, the capacitation of the sperm happen, and sperm has a capacity to fertilize only for 4 hours. So even if my timing of trigger, I adjust the dose and want to give at 10 a.m., 10 p.m. in the night, and 36 hours, 10 a.m. on Wednesday. Fine, my lab is open, patient can come. But her endogenous LH surge has happened and she ovulated on Tuesday morning, 10 a.m. The life of oocyte is just 12 hours. Maximum, you can say 24 hours. So I have done at 10 a.m. The follicle has ruptured on Tuesday and I am doing on Wednesday. That's not right. Your IUI, semen, wash semen should go as close to the time of ovulation as possible. So what I do in my center is I have given today on Monday, 5 p.m., next day, as late as 2 p.m., because my center closes 6 p.m., the semen sample washing and all will take another 1.5 to 2 hours. So what we do is the first day we call the patient as late as possible. We do the sonography. Now this time we don't use a condom. We use a disposable sheath and we see whether she has ruptured. If she has ruptured, we do only one IUI. If she has not ruptured, then we call the patient next day as early as 8:30 a.m. and we put our second load of a semen sample. Here, I'm very clear that the rupture of the follicle, even if it happens at 12 o'clock in the night, the life of a oocyte is there for another 12 to 16 hours. So my timing of insemination is as close to the ovulation as possible. And if with the SCG trigger at 36 hours, it means at 6 a.m. she ovulated. It means I'm doing at 10 to 12, 10 a.m. to 12 m.m. I'm timing my IUI will be as near to the ovulation as possible. And that's why we do one at 24 hours to catch up if anyone who has ruptured in 30 hours of ovulation. We catch them by doing 24 hours. That is, we catch them by doing next day at 2 o'clock or 3 o'clock first IUI. Now, in case if the follicle is not ruptured, we will still do the IUI, but we call the patient next day morning as early as possible. And if the follicle is ruptured, I will not call her next day. My single IUI is enough. Now, sometimes one tricky thing, one follicle may be 16, 17 mm, and the dominant leading may be 19.5. That will rupture at 24 hours. The other follicle may rupture at 40, 44 hours, little later, after they have grown, and then they will rupture. So what I do is, in spite of a IUI, I ask the patient to keep relation once at night. So suppose on Monday, I'm giving a trigger. Wednesday morning, also I have done IUI. Wednesday night, I ask them to keep one relation. Okay? And at 24 hours, if the follicle was not ruptured, I ask the patient. So tomorrow, if the follicle was not ruptured, I ask them to keep a relation even on Tuesday night. Believe me, the quantity of the semen sample may be less, the volume. Instead of 4 cc, they may give 1 cc at the time of a IUI, but the count will not be low. Nowadays, even in ART cycles, we keep the abstinence of 1 hour only. So the husband ejaculate and then sit, and we do the egg retrieval, and 2 hours of the egg retrieval, he will again give me a sample. So don't think 3 days, 4 days abstinence is needed. So I don't know whether the washed sperm has fertilized or unwashed sperm has fertilized. Makes no difference to me as long as fertilization and pregnancy has happened. So you decide depending upon what was your indication for a IUI. If it was a male factor, obviously relation is not going to happen. But if it is an endometriosis, PCOS, having relation once, maybe on a day of IUI night or next day night, on Wednesday night, let it be, but let them have the semen pool. Usually on Tuesday night, I ask them to have a relation if the follicle was not ruptured on a Tuesday afternoon. So I suppose the evidence tells us this is a beautiful studies where they have less than 36 hours, 36 to 37 hours. They have done IUI with this interval. And what they have found was at least 36 hours after ovulation, there is an increased pregnancy chances. But reading the publication and implementing into your practice, you need to be very practical about few things. And one of the things is, what is your timing of SCG trigger? And 36 hours when it is falling. So accordingly, friends, you do it. Now, semen samples. So I given the trigger. I know now timing of a IUI also. Now, what should be the semen parameters I should be accepting? The ideal semen parameters, if you see, many variables may influence the success rate of IUI, and it's logical to think that the sperm quality in native and washed semen has to be the main determinant to predict the IUI. The threshold levels of a sperm parameters above which IUI pregnancy is going to improve, or the cutoff, it needs to be studied. Unfortunately, it's very difficult because no publications are giving. This is a beautiful semen quality and prediction IUI. This is a beautiful systemic review. where 983 papers were reviewed and only 55 met with the criteria. And that's the reason there is no standardization even today. What should be your cutoff? But at least in a wash semen sample, it should be between 0.8 to 5 million, more than 4% morphology. And if you are saying the native sample, unwashed semen sample, please try to have 5 to 10 million. I do understand there are gynecologists who says, Are, we have given a pregnancy even with the 1 million unwashed semen sample. Don't do that. Don't consider that patient may be having variable semen count. So when you checked, it was 1 million, but when you did IUI, find out 1 million native sample, washed semen sample will be poorer, less than 1 million. It is not going to give you a success. So in my center, the cutoff is always between 5 to 10 million count, and the motility about 30%. Semen DNA fragmentation. Am I justified to do it routinely? No. No evidence support it. Only if it is an unexplained infertility, if it is a recurrent implantation failure in an ART cycle, or a recurrent pregnancy loss is the newer indication, we do the DNA fragmentation test. Now, if I have to talk about the semen, what is the procedure I should be following for the semen washing? There are two methods which are commonly used. One is a gradient method, and the other is swim-up technique. Many centers where the semen sample is normal, and if the IUI is for the male factor, then, IUI is for the female factor, maybe unexplained, maybe endometriosis, maybe PCOS, then they do the swim-up technique because there will be enough sperm which will come up and give you good sample. But usually, if it is a morphologically abnormal, go for the gradient method. Since in an ART, we use a gradient method only for a semen washing, in IUI, in my center, we use only gradient method for a semen washing, but you are justified to use swim up if the male partner is normal. Now, about the procedure. Type of the catheter, technique, whether I should do sonography or I should do single versus double IUI. I have already spoken to you about the last single versus double IUI. Now the procedure. First, I should have written timing of the IUI once the semen sample is given. It means ejaculation to insemination interval. It should be as less as possible. So if this person has given ejaculated semen, maybe you consider 20 to 25 minutes for the 30 minutes for the liquefaction and processing another 1 hour. By 1.5 to 2 hours, you should be doing an insemination. Now, where the hitch is, the gynecologist, now after the ART bill, this all has to be stopped because you cannot take the semen sample, wash semen outside the lab to any other center. Even if you are recognized ART1, it means you can do IUI. But if you are not doing the semen washing in your own center, you cannot take the sample out. So the IUI has to be performed in the IU center where the semen washing is done. That is, I think, is a very good government has put up, because I have seen centers washing the semen sample, sending it to the gynecologist. The gynecologist is busy doing cesareans. They, instead of 11 o'clock, the husband is sitting with sample in his pocket, and at 5 p.m., then the IUI has been performed. That I have already told you, 4 hours, the life of that. The sample quality has gone. So ejaculation, insemination interval, lesser the interval, better the results. Type of catheter. Remember one thing, there are several catheters in the market. There's nothing. Don't keep on purchasing very expensive. What is important, it should be soft, non-traumatic. and disposable. Soft catheter is the catheter you should be using. Now, the technique is usually when we are checking whether the patient has follicle ruptured or not, we also check whether the uterus is anteverted, acutely anteverted, mid-pose, or retroverted. If it is acutely anteverted, we don't ask them to void the sample. The full bladder itself helps us to correct the uterocervical or uterovaginal angle. And if it is a retroverted or mid-pose, we ask them to empty. You use the cusco speculum. Whether you remove excessive cervical mucus, usually don't do that, because if you try to take out with the insulin syringe, there may be negative pressure getting applied to the capillaries and there may be a bleeding. Only you can have a small Johnson & Johnson earbud and you can hold it with the Alice and try to remove any mucus plug which is coming in the way. You just pass the catheter loaded beyond, just 1 or 2 millimeters beyond the internal os, so that the retrograde flow doesn't come much. Once you pass beyond the internal os, slowly over the period of 1 to 3 minutes, instill the wash semen sample. The quantity of it should be 0.5 to 0.8 ml. Don't put too much, it will give a uterine cramps. Over the period of, usually we feel 1 minute ho gaya, but if you see the clockwise, hardly 20 seconds has happened. So have a patience and put it very slowly. And once you pushed everything, keep your catheter there only for 30 seconds to 40 seconds more, and then withdraw. This will also help to avoid the reflux. Now, usually, we don't have to hold the cervix. Your cusco speculum can help to adjust your full bladder or empty bladder. Very rarely, if you are not able to negotiate, then you can gently, don't put the catch on Alice, just hold and try to correct the angle. And if not, then at the internal os, just flush. Instead of doing a traumatic bloody technique, there is no harm in just putting at the internal os level and flushing in. Am I supposed to do under sonographic guidance? Those who are not doing the ART practice, routine gynecologist, if you don't have a sonography machine, don't bother. What does the evidence say? In my center, yes, we do it because my fellows wants to have a practice of doing a IVF embryo transfer. So here, under sonographic control, they take a what I can say, the embryo transfer catheter. We do the ETO, and then they load, they keep the outer catheter at the internal os, and they take this soft inner catheter inside and they just deposit at the mid cavity. This is for their own practice. They do it under sonographic control. The evidence, though, says that it may slightly improve your result. The cost, the centers, some centers in Western countries, the sonography machine, if you use, they put the cost of that sonography machine and makes the IUI expensive. Secondly, you need one person to hold the probe for you. So you need 2 fellows together, and that may not be possible. And that's why you don't need to do sonographic control. Pregnancy after slow release insemination versus bolus. The slow release has improved the pregnancy rate than the bolus going in. Ultrasound guided, yes. Conventional blind method for IUI is recommended for patient because use of ultrasound during insemination may increase the need of one more trained person, as I told you, and those who are putting the cost of a use of a sonography machine. For example, even in our corporate hospital, anytime I touch and I use it for my patient, they will be charged. So it will unnecessarily increase the cost. So no added extra benefits. Single versus double, as I told you already, the rates are similar and larger data needs to demonstrate whether you can do it double or single. Luteal phase, I'm going to cover a separate topic, which will be on second Monday of the next month, that is on 12th December. We will be talking about extensively on the luteal phase. Let's cover certain practical tips. Cervical mucus, as I already told. The rest after the IUI. Do you think you make them lie down for 10 minutes, it will help? It helps the patient's psychology. The sperm can go, they are not acted upon by the gravity. They can work on their own, they will swim up and they will go anywhere. But I have seen one publication showing 10 minutes rest after the IUI help. I think there is no science in it, but you imagine the patient feels, if I get up, everything will come out. And for her psychology, we tell her, lie down for 5-10 minutes and go. Now, how many cycles? Remember, IUI, first 3 cycles have a highest success rate. As the number of cycle increases, the success goes down. What we do in IUI? We are just concentrating on the release of egg and insemination of the sperm at the right time. So we are concentrating only on the gametes. We don't know whether the gametes are getting fertilized. There may be tubal block, sperm on this side and the egg on this side. There may be hostile atmosphere. There may be the zona on the egg may be very thick. There may be congenital absence of the enzymes at the acrosome, which are needed to penetrate through the zona. There are so many factors. And that's why there are 10% of the cases still unexplained infertility, because we can't explain whether the zona is thick and not in a routine patients where the eggs are getting released inside. So we concentrate only on a gametes. There may be associated endometriosis, tuberculosis, PIDs. It may not have been detected on sonography. And that is going to give hostile atmosphere for implantation. So we don't know whether the egg and sperm are getting fertilized, or if they are fertilized, whether the embryo is getting implanted, whether there is a problem in implantation. So we don't advise IUI more than 3 cycles in our center, but the evidence says sometimes you can plan 6 cycles. Believe me, if you don't get a success in first 3 to 4 cycles, less likely to get in subsequent. Months together, people keep on doing IUI, till the ovarian reserve of that lady gets exhausted, and then they advise IVF. Please don't do that. When will you switch to IVF? As I told you already. This is a very interesting study to conclude effect of gonadotroph type and an indication of a IUI. What does the success depend upon? They have studied more than 1,000 cycles, and they found that there are many variables, but the most important variable, thinking that we are doing a good monitoring, we are expert in monitoring, we are giving a right trigger at right time, and we are doing the procedure and the semen wash technique very good. Then the variables which affect is the age, the number of attempt of IUI, and the sperm quality. Younger the patient, better the result. First 3 IUI, better the result. More than 5 million sperm count with the more than 4% morphology and 30% motility, the results will be better. 4th IUI attempt, age more than 40, I will say more than 38. Total sperm count less than 5 million in native sample are critical in decreasing your positive clinical outcome. So that's what I say. If your IUI, first 2 IUI, you should get a result. Why? Because your selection, you are taking less than younger the patient. You are accepting your CME criteria, lowermost is 5 million. And that's why if you select patient good, you monitor her good, your simulation protocol are good, your lab is good, and your IUI technique is good, you should get the results good. So friends, I try to give you as much practical tip as possible. There is a vast, you can keep on talking entire day on optimizing IUI. Remember, we don't grow when things are easy. We grow when we face the challenges. Before I end, I appeal you. I'm going for my Foxy presidential election. They will happen in August, September 2023. Please use your Foxy membership number to log in, because everyone will receive the separate link. And please vote. It is your right to vote. Thank you by accepting that. I'm hoping that you all bless me and will support me and will help me. Friends, don't limit your challenge your limits. Each day we must strive for constant, never-ending improvement. Believe in chasing excellence every day. Don't think we are doing for decades, we can do everything right. Always keep your mind creative, thinking, when was the last time I did something for the first time? Because this life God has gifted us to bless so many families, to spread the happiness across the globe. And I don't think any other profession can be as beautiful as this profession. So friends, thank you so much. And I always like to thank my team. Before I end, the strength of the team is each member, and the strength of each member is the team. You should be lucky to have best team always. Thank you.
So, thank you, ma'am, for sharing your valuable insights. And the webinar was quite informative, providing practical solutions to the current needs.
When I give this talk, I never think that I spoke enough, because there are so many things one can talk on 1 hour. Anyway.
Correct. Thank you to all the dignitaries who have been a part of this interaction today, and your presence made it more meaningful. Once again, thank you so much, ma'am.
Thank you, dear. Thank you. Thank you.